Malignancies arising from the ovary can be grouped into three major groups. Those arising from the epithelium, from the germ cell, and the stroma. In this session, I will be discussing on those malignant tumors arising from the germ cells, namely malignant germ cell ovarian tumor, which constitute about 10 to 15% of all malignant ovarian tumors. Malignant germ cell tumor constitute about 5 to 15% of all malignant ovarian tumors, usually affects women of less than 30 years, but can occur in any woman, any age group, including the postmenopausal woman. It originates from the primordial germ cells of the ovary and can be grouped broadly into dysgerminoma and non-dysgerminoma types. Whatever be the different types, the appearance, clinical appearance and the appearance of the gross appearance of the tumor may be similar. They appear as unilateral solid tumors, rapidly progressing, presenting in all ages. And most often, they may be detected in early stages. And the clinical presentation may be abdominal distension, bloating, mass abdomen, or acute abdomen due to intratumoral hemorrhage or torsion. And they have a high propensity to metastasis and highly sensitive to chemotherapy. Dysgerminoma constitutes 0.9 to 2% of all malignant ovarian tumors, and it constitutes about 1/3 of all the malignant germ cell tumors. It has a very good similarity biologically to seminoma of the ovary. 90% of the women affected are less than 30 years. 10 to 15% may have a dystonetic gonads like 46XY, like in Sire syndrome, or dystonetic gonads like 45X or 46XS, or it may be partial dystonesis like 46XS. And this offers a prophylaxis for dysgerminoma. Individual with dystonetic gonads can be offered gonadectomy to prevent dysgerminoma. 10 to 15% of dysgerminoma occur bilaterally, and clinical presentation is as in general, like woman present with abdominal distension, bloating, pain, or acute abdomen due to intratumoral hemorrhage or torsion. And abdominal examination, most often there will be a solid mass, which may be mobile, usually in the early stages. Ultrasound may appear as a solid, heterogeneous, with marked vascularity. Microscopically, dysgerminoma appear as lobulated, soft, fleshy mass, grey-white or light in color. Microscopy contain syncytial trophoblastic giant cells, which secrete LDH, which may be used as a tumor marker for this tumor. It contains undifferentiated germ cells and large vesicular cells dispersed in sheets or cord, interspersed with scant fibrous stroma with variable degree of atypia. Mature lymphocytes and occasional granuloma intersperse the fibrous stroma. Immunohistochemical markers are CD117, OCT3, and OCT4. Surgery is the main mode of treatment, followed by chemotherapy. During surgical staging, ovariotomy, infracolic appendectomy, peritoneal biopsy, and removal of bulky nodes is done. Attempt to attain a zero residue or minimum residue is not necessary, because that may elaborate surgery may prolong or delay chemotherapy. And since this being a very virulent tumor, there should not be any delay in starting chemotherapy. And postoperative chemotherapy is given almost for all stages except stage 1A. And what we usually give is the platinum-based therapy, which includes bleomycin, etoposide, and cisplatin. With this regime, the most important complication is myelosuppression and pulmonary fibrosis. And every effort should be taken to preserve fertility in this woman, as removing the contralateral ovary doesn't affect the prognosis compared to removing the diseased ovary alone. So fertility should be preserved if the uterus and the contralateral tubes and ovaries are normal. Some cases, the both ovaries may be affected, especially in 10 to 15%, it may be bilateral. In such cases, the most severely affected ovary is removed, followed by cystectomy on the less affected ovary, which can preserve the fertility. The group non-dysolginoma include a variety of tumors. Of the most common is the yolk sac, otherwise called endodermal sinus tumor. It also include immature teratoma, choriocarcinoma, embryonal tumor, mixed cell type. Of the non-dysolginoma type, yolk cell tumor is the most common, but if you take all the ovarian malignancy, it's a very rare type of malignancy. Clinical presentation is as the same as other germ cell tumor. Woman may be presenting, the girl may be presenting with abdominal distension, mass abdomen or acute abdomen. An examination, a solid cystic mass, unilateral origin may be found. And tumor markers most specific is alpha beta protein. Other tumor markers like CA125, HCG, LDH may also be positive. VST may show solid cystic unilateral tumor showing hemorrhage or necrosis. Cross-sectional imaging showing wet honeycomb appearance. Management, as other germ cell tumor, is primarily surgery followed by chemotherapy. Fertility can be resolved if the other ovary and tubes and uterus is unaffected. It has a high malignant potential and had a bad prognosis. And prognosis mainly depend upon the stage of the disease. The more advanced, the more prognosis. Depending on the woman is more than 22 years, had a bad prognosis. And if the alpha beta protein level is more than 30,000, also had a bad prognosis. Recurrent disease has a bad prognosis. Should be meticulously followed up after chemotherapy. The chemotherapy used is the BEP regime as in other germ cell tumors, and follow-up should be mainly by the tumor marker alpha beta protein, clinical reviewing and imaging. And fertility should be, most of the recurrences occur within 2 years of surgery, and so should be avoided. The pregnancy should be avoided within 2 years of treatment. At the same time, if the woman survive and need not, after, if she can, most of the time she can have children, and there is no need for complete surgery after fertility as we do in epithelial or borderline ovarian tumor. Immature teratoma is one type of rare malignant ovarian tumor, which the incidence may be about 1% of the total malignant ovarian tumor, but it constitutes 1/3 of the germ cell ovarian tumors, and microscopically diagnosed by the presence of immature neuroepithelial cells in mature teratoma. No specific tumor marker is there, but there may be variable expression of CA125, alpha fetoprotein, etc. Clinical presentation is as other types of germ cell tumor, including abdominal distension, abdominal pain, or acute abdomen. But here, unlike other germ cell tumors, here the tumor had a grading depending upon the amount of mature neuroepithelial cells. If it's only sparse, it is taken as grade 1, and if it is very much abundant, it's grade 3. And the prognosis and management depends on the grading of the tumor also. Coming to the management, surgery is primary cytoreductive surgery is the management, which involves or takes every effort to preserve the contralateral ovary, tubes and uterus if it is not affected. And surgery should be followed by chemotherapy, except in stage 1A, grade 1, where only follow-up will be necessary. Growing teratoma syndrome is a rare complication of immature teratoma, which is characterized by metastatic tumor mass after complete eradication of primary with normal tumor markers. It can appear as tumor masses during or after completion of the chemotherapy. And these metastatic deposits are non-invasive, non-malignant, but has a propensity for rapid expansion. With this have a high potential for malignant change and may result in incurable malignancy. And these tumor masses are peculiar that they are often confined to the peritoneal cavity or retroperitoneum. Regarding the occurrence of growing teratoma syndrome, two theories have been postulated. One is chemotherapy destroys only the immature cell leaving behind the mature teratoma, or the chemotherapy may be causing metaplasia of the immature cells to mature teratoma. And as these tumors are highly resistant to chemotherapy or radiotherapy, complete surgical excision is the only treatment. And the risk factors for growing teratoma syndrome are gliomatous peritoneum, which is itself is a benign condition where there may be glious material can occur, where there is implantation of mature glial tissues in the omentum, which is a benign condition. But its presence can act as a risk factor for growing teratoma syndrome. Other risk factors are the high grades and the higher stages and incomplete resection during the primary surgery.